Okay, so interesting topic for me because I'm actually going into orthopedics, so it's about HIV. But my presentation is on pre-exposure prophylaxis for HIV. I have no disclosures. Learning objectives for today. First, we'll familiarize ourselves with the statistics of HIV, the groups affected, and the amount of new HIV diagnoses currently. Understand the pathophys and antiretroviral mechanism of action. Then move forward with reviewing the current PrEP treatment and the studies showing its efficacy. And then moving on to considerations for potentially you guys, the prescriber, and the future PrEP research. So my PICO question, does HIV pre-exposure prophylaxis decrease the incidence of HIV seroconversion in the men who have sex with men population compared to other at-risk groups? So first, statistics, pathophys, drug, mechanism of action. Here's a chart showing the diagnoses of HIV in certain subpopulations in 2017. So first, the men who have sex with men population comprising a majority of that pie there. So they are the biggest at-risk group with 66% of the diagnosis in 2017. Next, heterosexual men and women comprising 24% of that pie there. And then people who inject drugs are the next component of the pie. So a small subsection with heterosexual women and men, and as well as people who inject drugs, but men who have sex with men comprise a majority of the diagnoses. So again, common groups with new HIV diagnoses. The top here is men who have sex with men, and it's broken down by race. Bottom is heterosexuals. So it's broken down by sexual contact, but also by racial and ethnicity. So on the top there, again, you can see majority is men who have sex with men, but heterosexuals also are being affected by HIV. Again, people who inject drugs, small portion of that pie. Only 9% of people, of those that were seroconverting to HIV in 2016 were people who injected drugs. They only comprised 9% of the 40,000 diagnoses in that year. But again, it's important to recognize that these patients are at risk and they are actively seroconverting as well. So you guys might recognize this from Dr. Vinsor's lecture, but here's a brief overview of the pathophysiology. So first, the virus binds the T helper cells of the CD4 receptor and the chemokine receptor. It causes a conformational change. The viral contents are then dumped into the T helper cell. This is important to note. So reverse transcriptase is used to convert viral RNA into viral DNA. And then integrase is used to integrate that viral DNA into the host cell's genome. So a pretty smart virus, to be honest, and this is why we have such difficulty with finding a cure for HIV. Then the process of the normal processes of viral transcription using mRNA, ribosomes, things like that, manufacture new proteins. A virion is then created inside the host cell, and then the virion is then budded off to infect other T helper cells. It's important to understand the mechanism of action of these drugs. So first is to prevent viral entry. Another mechanism of action of some of the drugs is to inhibit reverse transcriptase, which is actually the mechanism of action of PrEP, or pre-exposure prophylaxis. Next, you can inhibit viral integration using integrase inhibitors, and then you can inhibit proteases. So many mechanisms of action, but we'll focus on PrEP. So PrEP, the current FDA-approved treatment, is Truvada. It's comprised of tenofovir disoproxyl fumarate and M-tricytidine. You'll hear me say TDF, FTC throughout the presentation. The types of drugs are 2 NRTIs, so those are nucleoside or nucleotide reverse transcriptase inhibitors. The dosage, 200 to 300 once a day. And it was approved for PrEP in 2012, but it was initially approved for to be a component of a robust HIV regimen in 2004. So it's been on the market for quite some time. So going back to our mechanism of action slide, this is where PrEP is working to prevent HIV seroconversion. If we zoom in here, you can see it uses, it inhibits the process of reverse transcriptase. So that's the mechanism of action of Truvada. So here, let's move on to the studies. First, in the men who have sex with men population, the first study is the IPREX trial. It's the most common study, and it's commonly referenced in the HIV community. Its purpose was to evaluate the safety and efficacy of once-daily oral Truvada as compared with placebo for the prevention of HIV acquisition among men and transgendered women who have sex with men. Results only showed a 44% reduction in HIV seroconversion, but 92% reduction in seroconversion in those who had detectable drug levels. There was about 2,500 individuals in this study that were seronegative initially, but it's important to note that in conclusion, adherence of the drug leads to higher efficacy of the drug. Moving on, the ANRS ecregase study, it examined if on-demand PrEP, meaning sexual activity-dependent PrEP, use, if that type of use still prophylactically protected against HIV seroconversion. Risk was reduced by 86% in the treatment group compared to placebo, and they concluded that on-demand use is effective, but you can't extrapolate this data to those who have less frequent sexual intercourse simply because on-demand use means they take the drug depending on how much sexual activity they have. The next study, the PROUD study, it attested the effectiveness of an open-label model, which means the patients know what drug they're taking. They're not blinded. There's no placebo. And so there was an immediate treatment group and a deferred treatment group. And the incidence was lower in the immediate treatment group compared to the deferred, and that corresponded to an 86% reduction in HIV seroconversion. So daily Truvada provided the best protection versus a deferred treatment. Moving on to the heterosexual population, first study, Partners PrEP trial. There were 4,747 couples enrolled in this study. They were all in serodiscordant relationships, and they were randomized into either placebo, TDF alone, or Truvada, which is TDF and FTC. There was seroconversion in 82 of the subjects. I think the biggest thing here is that there was a 67% and 75% decrease in incidence of seroconversion in the TDF group and then the Truvada group, respectively. So Truvada provided the most protection, but TDF alone also did provide some protection too. Moving on to the next study, the TDF2 study. This purpose was to determine the efficacy. Again, this is the heterosexual population of Truvada and sexually active heterosexual Botswanans. There was a 62.2% efficacy in Truvada in preventing seroconversion, so a little bit less. And then this was used in conjunction with other HIV preventative tools. So again, daily Truvada seems to work in the heterosexual population. Last study for the heterosexual population is the PrEP study. It was to determine PrEP's efficacy in HIV prevention in heterosexual women only. Now, it's interesting here because 33 women seroconverted in the Truvada group and 35 in the placebo. But I think the most important thing to note here is there was only detectable drug levels present in at the time when they were testing the drug levels in these patients or subjects, 28 to 37% of the time. So again, lack of adherence leads to lack of efficacy. So I think it's important to note that you must adhere to this drug in order for it to be effective. Again, small chunk of the pie, but important to note that people who inject drugs are actively seroconverting as well. They are at risk. So this is known as the Bangkok tenofovir study. It was to determine if TDF alone reduces HIV transmission in injection drug users in Bangkok, Thailand. They only used TDF, or tenofovir disoproxil fumarate. They didn't use Truvada. But 17 subjects seroconverted to an HIV-positive status in the treated group, and then 33 converted in the placebo control. Not a very good reduction in HIV incidence, but it still did provide some protection. So, in conclusion, some of the summary of these PrEP studies: it is effective. It's very effective in the men who have sex with men population, but also we did note that in going through those studies with the heterosexual population as well, it did provide additional protection. Adherence to PrEP is crucial and pivotal in order for it to be effective. And again, like I mentioned before, MSM population, highest risk, but you should also offer this to those that are at risk, maybe in serodiscordant relationships that are in the heterosexual population and those that are injecting drugs as well. So considerations when prescribing PrEP and future PrEP options. So considerations, there are some side effects, mostly GI-related, nausea, diarrhea, upset stomach, things like that. But most patients typically tolerate this medication well. Adverse reactions, I couldn't really find too many. Tenofovir disoproxil is renally excreted and can cause some decline in renal function. So, you definitely want to monitor this in your patients if you are prescribing this medication. It also has been noted to cause some bone mineral density loss in a very few amount of subset few subset of patients that they did these studies on. So again, something to consider if you do have a patient that's maybe frail, has a family history of osteoporosis, or maybe already has some underlying osteoporosis, you don't want to go prescribing this medication. Tests to order prior to administration, obviously making sure they're seronegative, they're HIV negative, which I'll go into further with the black box warning. But you also want to check, obviously, their renal function, and you want to check hepatitis B titers because you can actually reactivate hepatitis B if you're giving them Truvada. And then also testing for other STIs and things of that nature. Again, test to order throughout treatment. Every 3 months, probably want to check their renal function, make sure it's not declining. And then with regards to the black box warning, a little tough to see on the bottom here, but if we zoom in a little bit further, we can see the black box warning. You want to really make sure these patients are negative before prescribing this drug, simply because if you prescribe this medication and they're actively seroconverting, they can actually gain resistance to the medication, and it can be quite difficult to get them on an HIV drug regimen. So you really want to ensure that they're HIV negative or they're seronegative before prescribing. It can really complicate treatment in the future. So if they do have some sort of viral syndrome or something where they're feeling a little crummy, you have suspicion that they have acute HIV or they're actively seroconverting, really ensure that they are HIV negative because it can really complicate their future drug regimen. And then patient education, obviously educating your patients that other STIs are still possible. So educating them on safe sex practices and testing for other STIs throughout this treatment is really important as well. I can't tell you how much syphilis I saw. Future of PrEP. So these are actually current studies that are going on. So using Descovy for PrEP. So the difference between Descovy and Truvada is Descovy has tenofovir alafenamide fumarate versus tenofovir disoproxil fumarate. They both are NRTIs, but the difference is TAF actually has less renal effects. It doesn't hit their kidneys as hard, has less bone mineral density loss. So the studies are currently in phase 3 right now, and it's expected to end in July 2021. So this could actually be the new face of PrEP. They're both manufactured by Gilead Sciences, so they'll still make money anyways. But the study's currently underway, and this could actually be the new face of PrEP in the future. So definitely something to keep your eyes out for. And then cabotegravir for PrEP is an injectable form of PrEP. I think the main thing to take away from this is, as we saw, adherence is a huge, huge component of the efficacy of the drug. So if patients have difficulty or a pill burden with the once-daily regimen, this could definitely be an option for them in the future. It's in phase 2A right now. I think it's moving to 2B pretty soon, but it's an integrase strand transfer inhibitor acting on a different form of the mechanism or of the pathophysiology. But again, it can remove the pill burden, so you do an initial 4-week loading dose, and then every 8 weeks they come back for an injection. So a longer-acting form of PrEP could be an option for those that have difficulty taking a pill a day. They probably don't brush their teeth either if they're having difficulty taking a pill a day. But it could definitely be an option in the future. And it's definitely something to keep your eyes out for as well. So that is it. I put a corny picture of me at the A's Memorial Grove up there. And if anyone has any questions, yeah, that's it.
I'm just curious. Thanks. If you do prescribe the PrEP to your patients, is there anything you have to document to make sure that it will be covered by their insurance?
Oh, so yeah, insurance is actually kind of a huge issue with this medication. It's really expensive, but Gilead offers a copay assistance program. So typically they can have it covered. I know that under Medi-Cal, Medicare, those types of federally funded programs, it's a little more difficult. And they offer a rebate program as well. In terms of documentation, I'm not too sure. But I do know that Gilead does offer a copay assistance. And insurances typically are okay with it, but you have to bring like a copay assistance card from Gilead. So usually PrEP providers have this, and you can bring it to the pharmacy. They enter your information in, and it usually gets covered. So.
Well, she kind of stole my thunder, because I was wondering if it's Is it technically an elective, like medication, or because they're not diagnosed with it yet? So I was wondering about insurance coverage, but you answered it. So
Yeah. And I guess, I mean, essentially it is, but it's also a prophylactic measure. So it's protecting someone from getting
it's like a vaccine almost in a way.
Yeah. I guess, yeah, and it's protecting them from seroconverting. And I think, there's a big push right now in the medical community to, prevent. I mean, they're doing a lot of research on a possible vaccine for HIV. But I hope in our lifetime, and I'm sure we will see it, that HIV it's on the decline now. So we'll probably see it, hopefully see it eradicated. And I think it's also important to note that patients that do have HIV, if they're virally suppressed and if they're taking a robust regimen and they have been and their viral loads controlled, that they're essentially untransmissible, so they can't transmit the virus. So patients that are on HIV meds that are positive, they say undetectable equals untransmissible. And they did a study that showed that like 77,000 condomless sex acts between serodiscordant couples, there was not one single transmission of HIV. Yeah, so I think we'll see it. It's on the decline now. The biggest population that's being affected right now is African American males and Hispanic males, simply because I think it's access to care, but also it's kind of just lack of knowledge and education on the disease process. But yeah, I think in the future we'll see it eradicated. So yeah.
I was just wondering, as far as patients that are heterosexual that might be at risk, other than someone that has a known partner that it's tested positive for HIV, how do you identify patients who might be at risk or who might benefit from PrEP?
So I think it comes down to getting a good history, and just like any type of chief complaint or anything like that in medicine. Sometimes you have to ask really sensitive questions in regards to things like this. If they do have if they do have a partner that's seropositive and they're seronegative, asking them, is your partner on medications, or do you guys, how often do you guys have intercourse, or do you wear protection when you have intercourse? I think it's important to know, and then even just going as far as to asking what type of sexual activity they're going, because it's actually in rectal tissue or in so those that have penetrative anal intercourse, there's higher risk of transmission there, which is why you see it so affected in the men who have sex with men population. It doesn't really penetrate the vaginal mucosa or cervical mucosa as much, which it also comes back to the drug penetrance as well. That's why it's a little bit less effective in women, because the drug itself doesn't penetrate vaginal mucosa as much. So I think asking your patients what type of sexual activity they are doing and going into detail there gets you some more information. So, yeah.
So kind of along those lines, the groups that you cited in the beginning, were those people who are in monogamous relationships? And if those were excluded, are they still at high risk?
The heterosexual or the men who have sex with men population? So the men who have sex with men population, that wasn't a couples study. It was all of those studies were more so just, are they sexually active men who have sex with men? The heterosexuals, there was that one study that was just serodiscordant couples. But as far as that was the only one that I think had the serodiscordant couples. All the rest of them were just sexually active. So the men who have sex with men population in particular, it was just sexually active men and transgendered women who have sex with men.